Hi everyone, this is Ronesh Gupta. I'm one of the pediatric intensivists at McMaster Children's Hospital and also one of the members of the Liberate implementation team. Today I would like to review the rounding process and walk you through the latest iteration of our patient planning tools. First, I want to start off by discussing why we do rounds at all. More and more patient care is becoming an interprofessional effort, and rounds is meant to be a set, structured event where healthcare providers and even patients and families themselves come together to ensure all active problems are identified and that plans are in place to manage each. It is also an excellent time for education, not just for residents, but for all providers and families too. So why use a rounding format? Given the complexity of many of our patients nowadays and the large, diverse teams, there are a number of reasons we should approach rounds systematically. First of all, a structured approach helps ensure communication between team members is consistent and complete. Second, it provides an opportunity for everyone to give input on the patient problems. And finally, with the aid of some of our tools, we can keep plans purposeful and specific to the patient in front of us. The typical rounding process involves three basic steps. First, there is a data reporting phase where team members involved update the rest of the team on their progress. This data is then integrated into an overall impression and a shared mental model. Finally, the next steps are identified by defining short-term goals and plans to achieve them. Since there are many team members at rounds, a set process and role clarity is important to maintain efficiency. Remember that family members are invited to attend and engage in rounds as well. Data reporting usually starts with the assigned physician trainee presenting the patient's name, age, and why they are in the PICU, as well as the prioritized problem list. The other physician team members should have active roles. One should be writing and keeping track of orders, and another keeping track of the daily goals on the glass door. After the introduction, a systematic head-to-toe report of the patient is given by the multi-professional team members. The multi-professional team members should state whether or not they are achieving any previously defined goals and any reasons if not achieving. For example, the RT may state that they have not been able to wean the FiO2 as hoped and suggest maybe that it is due to recurrent mucus plugging or excessive sedation. If they are achieving goals, they should suggest a realistic next step to the team if they wish. After the data reporting, the assigned physician trainee should integrate and synthesize the information into a general impression of the patient, the overall trajectory, and any new problems identified. Finally, the physician trainee leads the team members in a shared model of setting goals and plans for the shift or the day. In the past, to try to help the physician trainees with this process, we used to have a separate daily goals checklist sheet that was supposed to be completed on every patient every day. Feedback, though, was that it was cumbersome and inefficient. So we've gone ahead and eliminated it, and instead we've integrated some of the planning principles into the handover list. But I want you to no longer think of this as a handover list. I want you to think of it as a patient planning tool instead. We want you to develop beyond the stage of being data gatherers and reporters, and this tool is meant to help you think purposefully about analyzing your patient problems and developing management plans. The tool is also really helpful for rounds. Basically, all the information in your introduction is here on the left. Start with the name, age, and PICU admission day. Then explain why the patient is in the PICU. Remember, this should reveal why the patient needed critical care support, so not just pneumonia, but instead pneumonia requiring CPAP. Then list the active problems, as well as any notable resolved issues that may help understand the patient's course thus far. For this reason, problem lists should be updated daily. Here's an example of how to introduce a patient at rounds. This is Jeremiah. He is 8 months old and has been in the ICU for 3 days. He was admitted for respiratory failure due to RSV requiring intubation. His active problems are respiratory failure, the RSV infection, inadequate nutrition, fluid overload, and impaired sleep. Previous issues of septic shock and anemia are now resolved. Remember, presenting is an important skill, and creating a good problem list is essential to becoming a consultant. This takes practice. Don't worry if you're uncomfortable developing a problem list for your patients when you first start. The ICU fellow or attending will be able to help you with this until you become more comfortable. Following the MD introduction, the nurse presents a systematic head-to-toe report. This will include, according to system, the RT report, dietitian, physio and occupational therapy, as well as the pharmacist's input. Each team member typically follows a script during their data report. This is what the nursing report looks like. Our expectation is that the vital details of the patient are systematically and comprehensively presented. For example, some standard things are, for the CNS system, the RAS, CAPD, and pain scores are presented. For the CVS, the heart rate, blood pressure, and perfusion are presented. And for GU, urine output and fluid balance are typically mentioned. The current status section of the patient planning tool is for you to include notes that you think you need for yourself to care for your patient. It is by no means meant or expected that you include all of your patient details or lab values, as these should be in your patient's progress notes. We do, however, expect that you know the important vital signs and patient details. For example, your patient's CNS status, level of cardiovascular or respiratory support, and nutritional intake. Please take a moment to pause the video and see what types of information you might include here. Following the head-to-toe report, integrate the data by giving us your updated impression of the patient. There's no need to repeat data that has already been reported. Instead, a tip is to start by referring back to the patient's status and trajectory as it relates to their reason for admission. The remainder of your impression should be a brief reflection on the active problems and mention any new ones that have arisen. Here's an example. Overall, Jeremiah's respiratory failure has stabilized, and I think he is ready for de-escalation. I also think we could further optimize his sedation, nutrition, and fluid status. After stating your impression, you may now describe your specific goals and plans for the shift or the day. It is not always possible, but wherever you can, try to state an objective goal, for example, a fluid balance or a pain scale score, followed by how you think you can achieve it. If your patient is already at their goal, you can state that too. Here's an example. For CNS, the CAPD and pain scores are on track, but I think the patient is in their stabilization phase, and nursing and I agree to target a RAS of 0 and reduce the fentanyl infusion to 1. CVS is currently unsupported and normal. Respiratory, I want to begin de-escalation. RT and I have set a goal of maintaining the FiO2 below 40% and trying to get the PEEP down to 6. We'll plan to make weans every 6 hours as tolerated. Nutrition has been below our goal. The dietitian and I have set a target accounting for invasive mechanical ventilation of 600 kcal per day. To achieve this, we will plan to increase feeds every 4 hours as tolerated. For GU, I would like to see the patient negative 100 by the end of the day, and pharmacy and I have planned to start furosemide every 8 hours to try and achieve this. From an ID perspective, the patient should probably receive a course of antibiotics for presumed superimposed bacterial pneumonia, and so I'm planning for 7 days total of either ampicillin or amoxicillin. Also, I would like to remove the Foley catheter. Physio is on board to try to increase mobilization, and we are targeting an upright seated position in bed today. As the patient is stabilizing, I don't think there's any need for routine labs. In summary, this video was meant to review the purpose and structure of rounds in the PICU and some of the tools we use to improve communication and collaboration. In the next video, we will show you how the Glassdoor project ties a number of these initiatives together.